Good morning. My name is Kar-Kit Wong. I'm a nuclear medicine physician at the University of Michigan. We're going to be going through PET-CT imaging of esophageal cancer. The objectives of the talk are to appreciate the diagnosis, staging, workup and management of esophageal cancer, to describe typical FDG PET-CT findings of the primary tumour, regional and distant metastases, to review indications and test performance of FDG PET-CT for staging and restaging compared to standard anatomic imaging, CT and endoscopic ultrasound. A question: which of the following statements regarding FDG PET-CT imaging of esophageal cancer is true? A. PET-CT has a high, greater than 90% sensitivity for detecting T1 and T2 primary esophageal cancers. B. The introduction of PET-CT for preoperative staging has made CT and endoscopic ultrasound obsolete. C. PET-CT has superior specificity than CT and endoscopic ultrasound for staging of regional nodal metastases. And D. PET-CT performs poorly for detecting distant metastases to bone. Esophageal cancer is a rare tumour, 10% of all gastrointestinal malignancies, with a poor 5-year survival between 14 to 20%. Squamous cell cancer accounts for 50 to 70%, and adenocarcinoma 30 to 50% of all cancers. Squamous cell cancer affects the middle and distal thirds, and alcohol and smoking are risk factors. Adenocarcinoma is becoming more common and affects the distal part, and this is associated with Barrett's esophagus. Only 15% of esophageal cancers are proximal third tumours. The esophagus does not have a serosa, therefore infiltration into the mediastinum occurs early. The esophagus is lymphatic and vascular rich, therefore it's prone to having early nodal and distant metastatic disease. Distant sites are the liver, adrenal, lung and bone, with spread at diagnosis of 20 to 30% of cases. Early stage disease is often asymptomatic. However, late-stage disease presents with dysphagia due to obstruction. Staging of esophageal cancer follows the American Joint Committee on Cancer 7th edition TNM staging system. The 7th edition defines regional nodes to the level of the celiac axis. The number of disease nodes may be more important for prognosis rather than the actual sites of these nodes. This is an example of the T staging system. A TX score is when the primary tumour cannot be assessed. Very early small tumours are T1, T1b invading the submucosa, and large invasive tumours are T4, being T4a resectable or T4b unresectable. In terms of the end stage, when you have N0, there's no evidence of regional lymph node metastases, and then you can have N1, N2 or N3 disease depending on the number of lymph nodes. The individual T, N and M scores are combined to reach a stage 1 to 4, with 4 being the presence of distant metastatic disease. 54 to 69% of patients are eligible for surgery. The mean survival after surgery, however, is only 13 to 19%. Neoadjuvant chemotherapy and external beam radiation therapy prior to operation is gaining acceptance. The conventional workup is fluoroscopy, CT, MRI, endoscopic ultrasound. PET-CT, positron emission tomography with hybrid CT, using 18F fluorodeoxyglucose is a relatively new imaging modality. Adenocarcinoma and squamous cell carcinoma have overall similar metabolic signatures. Adenocarcinomas, mucinous types near the gastroesophageal junction, may have slightly less FDG uptake than squamous cell cancers. The majority, though not all literature, support the intensity of FDG uptake as correlated to survival. FDG uptake is a prognostic indicator. Primary tumour SUVs of less than 3.0 have better survival. Prognostic indicators such as the length of tumour, number of N1 positive lymph nodes and distant FDG avid sites also predict a lower survival. Indications for PET-CT include a strategy to detect distant metastases at diagnosis, improving the specificity of lymph node staging, combining PET-CT and endoscopic ultrasound guided biopsy as a preoperative workup for the highest nodal yield. PET-CT performance. For local regional staging, PET-CT has a sensitivity of 51% and a specificity of 94%. For distant staging, it has a sensitivity of 67% and a specificity of 84%. For the primary tumor, PET-CT has overall sensitivity of 80% for primary esophageal cancer. The sensitivity is close to 100% for large tumors T3 and T4, but the sensitivity is only 43% for smaller T1 tumors. PET-CT cannot detect in situ or T1A tumors. PET-CT cannot determine the T stage of an esophageal cancer. This is a PET-CT scan which shows intense FDG uptake in the distal esophagus. The fusion FDG PET-CT images show that it's localized to the distal esophagus. This image shows the PET on the top and the fusion PET-CT on the bottom. There are FDG-avid lung nodules compatible with nodal metastatic disease. This is a different case. There is intense FDG uptake which localizes to the upper cervical esophagus with circumferential mucosal thickening. This is compatible with a cervical esophageal cancer. This PET image shows FDG uptake in a prevascular lymph node. This is compatible with nodal metastatic disease. This axial image shows FDG uptake in a lung nodule in the right middle lobe. This is compatible with lung metastasis. Some pitfalls of FDG PET-CT are that mild esophageal uptake with an SUV max of less than 4 may actually relate to esophagitis or low esophageal sphincter activity. Hiatal hernias, benign stricture after dilatations, post-biopsy, and esophageal leiomyomas can have mild FDG uptake. These are sources of false positive results. Small intracapsular nodal metastases have a high false negative rate. Intense uptake in the primary tumor may obscure subtle abnormal adjacent nodes. Synchronous primary neoplasms are found in 5.5 to 8% of patients with esophageal cancer on PET scanning. PET-CT compared to CT and endoscopic ultrasound combination for nodal staging shows that PET, although being less sensitive, 22%, has a very high specificity of 91% compared to CT/EUS, 83% sensitivity but only 45% specificity. Therefore, the combination of PET-CT and CT/EUS would have the highest diagnostic accuracy. PET-CT versus CT for distant M1 disease, the PET scan has a sensitivity of 69% and a specificity of 93%, whereas the CT has only a sensitivity of 46% and a lower specificity of 74%. And PET-CT versus CT for M1 bone disease, the PET has a sensitivity of 92% and a specificity of 94%, which is superior to CT of 77% and specificity of 84%. This is a case showing FDG-avid bone metastases, and the arrow is localizing lumbar spine bone metastases in this patient with esophageal cancer. These axial images show FDG-avid rib metastases. This image in the same patient shows FDG-avid bone metastases to the right pubic symphysis and the left femoral head. The impact of PET-CT on patient management is that it will change staging in 14% of patients. PET will find distant metastatic disease in an additional 5 to 8% of patients after conventional imaging workup. PET is insensitive for local regional disease and does not replace CT/endoscopic ultrasound for detection of nodal disease. PET is more specific than CT/endoscopic ultrasound for regional distant disease. Using PET-CT for detection of recurrences, 2/3 of patients relapse within 1 to 2 years after their diagnosis. For restaging, PET-CT has been shown to have a sensitivity of 94% and a specificity of 82% for detection of recurrent metastatic disease. PET is not clearly better than the conventional modalities CT and MRI. PERSIST is an acronym for Therapeutic Response Criteria based on PET imaging. RECIST is an acronym for Therapeutic Response Criteria based on CT, which looks at changes in size of tumor sites. By using PERSIST criteria, which is based on the metabolic signature, which is the FDG uptake in tumor and the changes after treatment, treatment response monitoring is better than using the older RECIST criteria. Responders versus non-responders on early response PET-CT is associated with better survival in some studies, with a threshold of SUV reduction between 30 to 80% being advocated. PET cannot exclude minimal residual disease, as there is cases of significant recurrence even after an SUV decline. So going back to the multi-choice question from earlier, which of the following statements regarding FDG PET-CT imaging of esophageal cancer is true? The answer is C, that PET-CT has superior specificity than CT/endoscopic ultrasound for staging of regional nodal metastases. Therefore, the combination of PET-CT with CT and endoscopic ultrasound together would have the highest diagnostic accuracy. Some take-home points. Esophageal cancer is a biologically aggressive, metabolically active malignancy. FDG PET-CT is a useful imaging modality for staging and restaging of esophageal cancer, prognostication, and assessing treatment response. FDG PET-CT has good specificity for local regional nodal metastases. FDG PET-CT is a whole-body technique with good accuracy for distant metastatic disease. This is a bibliography of relevant articles on PET-CT for esophageal cancer. So PET-CT is a relatively new, very powerful imaging modality for the diagnosis and staging of a wide range of cancers, including esophageal cancer. I'd like to thank you for your participation in this educational lecture. Hope that it's been helpful. Thank you.